All right. Okay, here we go. Well, good morning, everybody. So I'm glad to have this opportunity to speak to a few of you guys this morning. Unfortunately, Erin Donatelli and Jennifer Hardesty were not able to help out today, so they asked me to do it, and I am gladly accepting. So my name is Janee Parson. I am the lead consultant pharmacist for the Mid-Atlantic Region, so I take care of our consulting team all along the East Coast down here. Sounds like a lot. We don't have too many, but it sounds good, right? I've actually been a consultant pharmacist for going on 27 years, and all of my years in consulting have pretty much been with the same company. So I'd like to say I've been with Remedy that long. It hasn't actually been called Remedy that long, but if you've been in the long-term care world, you know of Woodhaven Pharmacy, and that's where we got our start. So when I started consulting, I was hired with Woodhaven, and I've stuck with them pretty much this whole time. So that's been my experience. And I do service nursing homes and assisted livings in the Baltimore area. So just a little bit about me. So today I just wanted to touch on making the most of your pharmacy partnership with your consultant pharmacist, and a little bit of a focus on deprescribing and polypharmacy. So some of the things that your consultant pharmacist can definitely assist your facility with, if you work in skilled nursing facilities, assisted living facilities, I have a handful of things listed here. Today we're talking about deprescribing, which goes right along with polypharmacy. Obviously, we're trying to get rid of some of these medications that perhaps we can. Certainly, we can help with MedPass optimization, which kind of goes along with the deprescribing, as we might be able to decrease the number of medications. Certainly, the number of medications we're giving per MedPass, maybe eliminating some of those MedPasses. When you actually take a look at it, it seems like, there's meds scheduled all day long. It's pretty crazy when you actually look at it. And we do have some great tools in our pharmacy portal that lets us look at those different MedPass times. And it turns out to be a lot. Also, we can also help with copy projects. So if you have any sort of medication concerns that come up, maybe some trends that you're seeing at your facilities, we can certainly be available to help run reports, do some assessments, that sort of thing. Any type of education that has to do with medications, medication use, medication monitoring. Certainly we're there for that. And survey support, certainly when survey teams walk in the building, give us a call, let us know they're there. If anything comes up, tell the surveyor that you'll get back to them. You can give us a call. We can certainly take a look at things and, even offer to speak to surveyors, and a lot of times that will help. So those are just a handful of things that the consultant pharmacist can partner with you to do and assist you in medication management. So moving on here, deprescribing. For some reason, my screen is kind of wonky here, but I'm going to run with it. So polypharmacy is a buzzword I'm sure we have all heard. Kind of simple. It's basically somebody who is taking either multiple medications for treating one particular condition or diagnoses, or it can also be the total accumulation of medications that a resident is taking to treat all of their comorbidities. So they say polypharmacy is somebody being on 5 or more medications, which I am not sure where everybody practices, but I can tell you 100% that none of my facilities, and probably in the 27 years I've been doing it, have an average that is anywhere near 5. Hyperpolypharmacy is actually another term for residents who receive 10 or more medications, and that's generally where my folks land. Usually, I want to say between 12 and 15 is what we see. Polypharmacy kind of sounds like a bad word, and maybe, this is a bad thing. And certainly, if the medications aren't being used appropriately, yes, it can be a bad thing. Or if the residents are having side effects, any sort of effects related to how many medications they take, that is a bad thing. But sometimes we actually need to use more medications for our more acute residents. So if you practice in a setting where they might do dialysis, they take a lot of dialysis patients, or they might have an on-site dialysis unit. If you have a vent unit, if the facility actually takes a lot of high acuity psych residents, those residents are generally going to be on more medications. So that's going to make your numbers go up. So it's really just a process of making sure that everything that they are taking are things that they need and that they are safe. Obviously, this is something we see most commonly in the elderly. They generally use more medications than anybody else. And certainly the population that we see uses medications because, they're in a facility for a reason. And we don't want to just look at prescription medications. It's going to include over-the-counter meds, any sort of dietary supplements, vitamins, herbals. And I do see in my assisted livings, a lot of families really like their loved ones to be taking quite a few different supplements. So sometimes it makes it difficult trying to figure out what's in a lot of these products, but we can't forget about those as well. There are a lot of consequences to polypharmacy. Increased healthcare costs. Certainly the cost of the drugs will increase healthcare costs. If there's any sort of event related to them being on too many medications, which some of these other things I'll touch on, that lead to hospitalization, that will increase healthcare costs. We will increase healthcare costs by increasing nursing time, having to have them pass all these medications to these residents and chart for them, all the documentation that they need to do. All of those work into increasing healthcare costs. Of course, adverse drug events, which is the ultimate thing we want to prevent, but being on many meds is going to definitely increase your risk for that. Drug interactions. It seems unlikely somebody can be on 12 medications without there being at least 1 or 2 interactions going on to some extent. Not all interactions are things that we have to, stop a medication for, but they're good to be aware of. Medication non-adherence. Certainly, 98-year-old Mrs. Jones might not want to take 12 medications every morning, so she might refuse. Functional status, cognitive impairment, and falls, those kind of all go together. We can see those. Decline in functional status, impairment in how they're thinking with confusion. That's a side effect of a lot of meds. Certainly those things can lead to falls. A lot of medications have anticholinergic side effects, and they can cause, we're trying to treat incontinence, and certainly that can also lead to falls. And also changes in nutrition. Maybe they're taking a lot of medications and they're nauseous and they don't want to eat. So all of those things can be consequences of polypharmacy. So deprescribing is a process that we can use to help to rectify polypharmacy or at least reduce polypharmacy. So I have a couple of slides here about the process basically. So we want to identify priority medications to discontinue. So there's kind of 2 ways to go about this, but certainly in the end, we really need to have it be a resident-specific focus. So we can think in our head of a couple groups of medications, classes of medications that we might want to look at, and that might be a good place to start for deprescribing. So I think of things like proton pump inhibitors that we use a lot of time for reflux disease or GI bleeding. So our Prilosec, our lansoprazole, Prevacid, Nexium, esomeprazole. So those drugs are a good place to start a lot of times. And we do kind of see overuse of these drugs because a lot of times our residents that are coming to us from an acute care setting will have been started on that in the hospital to prevent stress ulcers, because certainly being in the hospital and having all kinds of procedures and surgeries and whatnot increases their risk of stress ulcers. So they get put on this. Usually it's a protocol. And then when they come to us in the nursing home, it's continued. And a lot of times we kind of slap on the diagnosis of GERD because it's a common diagnosis. And then the resident kind of carries that with them, going forward. It's just something that's now a part of their medical record. So it's something that I like to start with when I'm thinking of deprescribing, just because I think a lot of folks probably don't need to be on them routinely. And there are more side effects than, we realize from these drugs. They're fairly safe, but they do cause side effects, and we do see them come up. So we can pick a drug, but we don't want to go across the board and say, okay, let's get rid of everybody who's on a proton pump inhibitor. So obviously we can't do that. We need to be more patient resident specific to find out exactly why they're getting it and if there's a good reason to keep them on it. So certainly we want to develop a follow-up plan so we can plan to discontinue something, but we also need to follow up on that and make sure that that was a good choice, to make sure that their symptoms didn't recur. So we want to do that. Before starting any new medications, we want to consider underlying causes of whatever we're starting a new medication for. maybe non-pharmacological interventions could be tried first, and also looking at risk versus benefit. And a little example I have here is one of my colleagues, she was reviewing charts and she found a resident who had been started on Ritalin, which is a stimulant, and they were using it for her as an adjuvant for her depression. She was really withdrawn, staying in her room. So they wanted to kind of try to perk her up, see if we can get her out, participating in activities and socializing. So they started her on Ritalin, and it was given twice a day. 2 weeks later, when the nurse or the doctor saw her, again, the resident was complaining of not being able to sleep well, that she had trouble falling asleep, and that she woke up several times during the night. So the reaction from the physician at the time was to start her on a sleep aid. But she probably should have looked back to see, well, I started this Ritalin a couple weeks ago. Ritalin is a stimulant. Let's see what time we're giving that second dose. Maybe we can decrease the dose and hopefully help her sleep better, or change the timing of the second dose, or some sort of alteration in how that was being given to help the problem, rather than adding on another medication. And I think this is a common problem, especially when we're calling on-call physicians about a certain issue that a resident is having, just because a lot of times they don't know the residents as well, and they just might add on a new medication rather than trying to decipher why exactly the symptoms are occurring. So that can help on the front end with deprescribing. And then again, if a new medication is added, we should always kind of consider it as a trial, and again, review it in 1 to 2 weeks to see how they are doing, to see if it's something we should keep. So this next slide is talking about the more resident-centered approach, and I did touch on that we need to assess each resident specifically to see what their diagnoses are, what their history is, and if we can see if they've taken something in the past that has been successful, or if we can see if they've taken something in the past that maybe didn't work for them, and that is documented. So we want to just pretty much decide what the goals of our therapy are going to be, what we want to treat, what we think, maybe we can get away with treating with 1 drug versus 2. Identify medications with potential risks. So we have some tools that I'm going to talk about in a minute that can help us identify those. We want to stop or reduce the dose. So deprescribing can also mean just trying to reduce the dose gradually and eventually discontinue. That's all part of the process. We want to communicate, make sure that the family is aware, make sure nursing is aware of what we're trying to do, just so that they can watch out for, any sort of recurrence of symptoms. And then monitor regularly for adjustments, making sure that we've made the right decision in actually deprescribing that particular drug. There are a lot of tools out there to help us decide what medications might be best. We have the Beers list, which I'm sure everybody's pretty familiar with. There are start and stop criteria tools that are also evidence-based recommendations. CMS has different pathways that they use, and they do use these pathways when they step into our facilities. They have certain pathways that they look at, and they do have a pathway for medication management. So sometimes it's good to take a look at that to see what they're actually looking at. Choosing Wisely, I believe, is a program put out by the American Geriatric Society, and they have collaborated with professional organizations to get recommendations on choosing medications wisely. So they also have several, you can look up, based on cardiology or respiratory. So you can take a look at those to see what medications they do recommend, what they don't recommend. And then there's also, if you can Google a deprescribing toolkit that has a lot of things you can help, that can help you with deprescribing as well. And certainly your consultant pharmacist can help you track down some of those tools if anybody has any interest in that. Just talking real quick about the Beers list medications. So we know this is a list of drugs that are considered potentially inappropriate to use in geriatrics. That doesn't mean these drugs should never be used and that it's inappropriate for everybody, but it's really just something for us to stop, take a look at, and know that we need to use them with caution, and then use them with common sense, it says. So basically we need to be monitoring for the things that could be an issue, but just to know. So just to know that it's not, if we have somebody that's on a Beers list med, that doesn't mean we have to stop it. We just need to make sure we are monitoring that appropriately. The start and stop criteria, again, is used to identify red flags that may require further intervention by the medical team. So it's like the Beers list in that, these are suggestions, recommendations, but they're not, you have to stop this, or they cannot receive this. So, and the acronyms there, the START is the screening tool to alert doctors to right treatment. And there's 22 of those recommendations. And then the STOP criteria, which are a screening tool of older persons' prescriptions. And there's 65 of those recommendations. So those just go over appropriate or, more appropriate drug use, and just alerting us to some of the things that can happen. I mentioned choosing wisely, and these 5 bullet points happen to be contribution by the American Society of Consultant Pharmacists. But remember, I said that there was a collaboration between all disciplines, many disciplines. So taking a look at that, is actually really good. And I've learned some things when I look at that actually. So, but those are all good points to remember. So you can search that or ask your pharmacist to help you out with that. I also want to touch real quick on the MedPass optimization that I touched on earlier. So certainly the goals of the MedPass optimization would be to reduce the number of medications, a lot like what, the deprescribing, and this can also be, part of our deprescribing process. Reduce the monitoring of medication. So it doesn't always have to just be getting rid of the medication, but if we have somebody who's on a 3-time-a-day blood pressure medication and they're, a long-term care resident and they have parameters with their blood pressure medication, do we need to be checking that 3 times a day when they've been stable for a year? And also, obviously, to reduce the number of med test times, which I told you can get a little crazy. So this should be a resident-centered process. We want to make sure all our medications have an indication for use. And we want to look at medication orders that take a lot of nursing time, and we list sliding scale insulin here. We know if somebody's on ACHS sliding scale insulin, that's a lot of nursing time to be taking all those finger sticks. And we know that the American Dietetic Association does not, sliding scale insulin should not be used for management of diabetes. It's an acute, something that when they're in the hospital, it's very useful because a lot of times we lose control of their sugars when they're in the hospital. So it's definitely useful there, but when they come to us into a more stable environment, it's very important to get them away from that sliding scale insulin and onto a better regimen. So again, expanding it beyond medications, reducing unnecessary monitoring, and also consolidating lab draws so that we're not doing that all the time. And if you look at this is just a report that we are able to print for our facilities, and you can see all these different MedPass times. So look at during the day, there's just seems like there's medications given all day long. So if we can try to reduce that is so beneficial to nurses. We also remember that we can relax the MedPass times. We can go to a more, resident-centered, just given the AM versus having a specific time. So we do have facilities that actually go through that process of changing all their meds to be for a time period versus just an actual time. And when we always worry about the 1 hour before and 1 hour after window. So this really eliminates that. So it does take a lot of pressure off the nurses. We can identify meds that are given 4 to 3 times a day and maybe get them down to twice or daily. So there's a lot of meds now that come in a long acting formulation. And if our residents are able to swallow those, we can switch them to that perhaps. And that's going to cut down a lot on their MedPass times and a lot of the pill burden that they are receiving. So that also, will help them in that way. But those are just some of the ways we can help facilitate the facilities working with medication management, really anything. So anybody have any questions? That's all I have for you guys. And I hope maybe you learned a little bit. Any questions?